A very unfortunate boy with a spear pectus ectobitum had previously failed a nurse procedure that led to an even more severe deformity. How can the reoperation be successfully completed? This is the unfortunate 14-year-old boy from northern China. He had undergone a nurse procedure at a local hospital for pectus ectobitum, which was unsuccessful and resulted in failure. In order to operate again, the patient was admitted to our hospital. The patient was diagnosed with pectus ectobitum when he was a child, and his anterior chest wall was depressed. Due to the severity of the depression and the abnormal breathing, the patient often suffered from colds and pneumonia in his childhood, and his physical fitness was very poor. With the increase of his age, his depression became more and more severe and gradually became noticeable. After activity, the patient would experience palpitation, short of breath, and not be able to exercise vigorously. Due to the severity of his condition, he had to undergo surgery 3 years ago. The surgery was done at a local hospital using nurse procedure in which a steel bar was placed inside his body. However, the operation was not successful, and the depression of the anterior chest wall did not disappear after the operation, but gradually distorted the chest wall, and the deformity worsened. In addition, the incision in the chest wall on both sides never healed. The incision rapidly separated, became infected, and had to be treated with frequent dressing. After the surgery, the patient was very painful, often felt chest pain, and was unable to bend properly. The surgery caused great trouble and annoyance to the patient and his family, who were not satisfied with the results of the surgery, but local doctor insisted that the surgery was effective and instructed that the steel bar must be left in the body for 3 years before it could be removed. The patient followed the doctor's instruction and persisted for 3 years. After 3 years waiting, the patient came to our hospital for thorough treatment of the deformity. After admission, we performed a physical examination of the patient, which showed that he had a large area of deep depression in the anterior chest wall and 6 surgical scars on both lateral chest wall, 4 of which did not heal. Pus was drained from 2 incisions. A steel bar was visible in 1 of them, and heartbeat was visible on the left chest wall. Imaging study shows a severe depression of the anterior chest wall, a left shift of the heart, and a severe compression. A steel bar and the short fixed implants and its both sides could be seen in the body, and the position of the steel bar was not at the bottom of the depression but below the depression. There was no supporting effect on the depression. The last part of base of the anterior chest wall plunged dorsally along the right side of the spine beyond the front of the spine, and there was no gap between the two. The Haley index is unmeasurable and negative. The patient was diagnosed with a very severe pectus ectobitum after failure of nurse procedure. Because the patient's condition is extremely bad, there is a clear indication for surgery, which must be performed as soon as possible. After adequate preoperative preparation, the surgery was performed under general anesthesia. Supine position was adapted. After full disinfection, skin incisions were made through the scars to find the steel bar in the body and remove it. Then the correction was carried out with 1 procedure and Wenlin procedure, and the correction was completed with 3 bars. Finally, the satisfactory results were obtained. The patient's surgery was a repeated operation after the failure of nurse procedure due to the complexity of the deformity and the special condition. It was extremely challenging. The challenge of the surgery came from 2 main aspects. The first was the severity of the deformity, and the second was the trouble that comes from the first surgery. At present, the international accepted index to measure the degree of pectus ectopiderm depression is the Hiller index. The index is the ratio of the transverse diameter of the thoracic cage to the distance from the bottom of depression of the anterior chest wall to the anterior edge of the spine. In general, a value greater than 3.25 is an indication for surgery. However, in this patient, the Hiller index could not be measured because the distance from the base of the anterior chest wall depression to the front of the spine could not be measured. In other words, the index was no longer the parameter in the usual sense, but an absolute negative value. When this happens, it means that the deformity has become the most severe type of pectus ectopiderm. Clinically, the vast majority of the patients with pectus ectopiderm do not have this condition. There are few reports of such serious cases in the literature. This also proves the severity of the deformity in this patient. The most popular surgery for pectus ectopiderm is Nuss procedure. For general pectus ectopiderm, this procedure will have better results. However, for patients with extremely deep depressions, it is difficult to complete the treatment with a classical Nuss procedure. The failure of this patient's first surgery is a testament to this fact. The second trouble with this surgery is the various drawbacks that come from the first surgery, the biggest of which is adhesion with the chest cavity and medius sternum. The deformity itself causes a gap between the base of the anterior chest wall and the spine, which combined with extensive adhesion makes reoperation difficult. In addition to this, the first surgery disrupted the structural integrity and normal anatomy of the chest wall on both sides, which also caused problems for the second operation. Analyzing the reason for the failure of the first surgery can draw many lessons. For example, there are serious problems with the lumbar curvature, the position of the stubas, and especially the surgical method itself. These factors synthetically exert a chemical reaction at the same time and ultimately succeed in the failure of the first operation. Reoperation is extremely risky and difficult. The risk mainly comes from the damage to the heart. Because the anterior chest wall is close to the heart and there are severe adhesion, it is extremely dangerous to place stupa on the surface of the heart. The difficulty of the surgery comes from many aspects, including the severity of deformity itself, severe adhesion in the chest cavity, and destruction of the lateral chest wall structures. In order to eliminate the risk and reduce difficulty, we have made a detailed design of the surgical strategy. We first pre-shape the anterior chest wall to reduce the stress of the structures and increase the mobility of the anterior chest wall, and then we performed one procedure which is done with two stupa. After the completion of the Wung procedure, the major deformity of the anterior chest wall was eliminated. On this basis, we implemented the Wenlin procedure to completely correct the residual deformity. After all the surgery was successfully completed, the anterior chest wall deformity disappeared completely and the chest wall appearance returned to normal. The procedure was safe and smooth without any complication. In my daily clinic work, I have encountered many cases of a failure of Nuss procedure. Since my hospital is a specialized chest wall surgery hospital and the largest deformity correction center in our country, I have seen a large number of such failed surgeries in the world. Failure of surgery is a miserable thing. The reason for failure comes from many sources, but the most important reason comes from the doctor's cognition and technology. If the doctor cannot accurately understand the operating principle of the operation and cannot master the surgical method proficiently, it is easy to lead to the failure of the operation. I want to emphasize here that Nuss procedure, the well-known famous and useful procedure, is not a panacea. For many types of pectus ectobitum, this procedure does not work well. If doctors continue to use this technique, the surgery may fail. Failed surgery is a very painful thing for patients and their families, and I have seen many unfortunate patients with my own eyes. They came to our hospital from all over the world and with their first surgery at different levels of hospitals, and some even came from the top hospital in the world. Their misfortune was distressing and sympathetic, and they need my help. In the following videos, I will gradually introduce these cases to help more doctors improve their surgical skills and avoid any failure. I'm Dr. Wang from China.